So good morning to one and all present here. I am your host Shweta Patil for the day, and we are here live from the International Hall B. And without any ado, let's start with the session. So first speaker for the day, we have Dr. Fatima. Over to you, ma'am.
Thank you. Let me see, how can I get my slides up? Let's see, let's share screen.
Ma'am, you can start sharing the slide.
Bear with me, I know I should know by now. Okay.
Ma'am, right at the bottom, you'll find your,
Yeah, is that good?
Yes, ma'am. You can just optimize the screen, ma'am. Yeah.
Okay. So I'm going to hide the video. I would like to thank the organizers for inviting me to present. I'm Fatima Ghassia, Associate Professor of Ophthalmology at Cleveland Clinic and Director of Vision Neurosciences and Ocular Motility Lab at Kola Institute. And today I'm going to talk about fixation instability in amblyopia. I'll first briefly describe fixation eye movements and their functional significance, and then talk about the FEM abnormalities in amblyopic subjects and discuss the implications of FEM abnormalities on visual function deficits and treatment response. So a couple slides on some basic science. I can't advance my slides. Oh, here it is. Okay, let me try. Yeah. So visual system has a built-in paradox. We must fixate our gaze to inspect minute details of the world. However, if we fixate perfectly, the entire world would fade from view because of neural adaptation. So let's take an example here. If I have you look at a black cross, after a few seconds, the purple circles, they begin to fade from perception. If you move your eyes, those purple circles are visible. And this phenomena is called Trochlear Fading. It is an optical illusion that occurs when one fixates at a particular point for even a short period of time, an unchanging stimulus away from the fixation point begins to fade and disappear. Thus, during fixation, to thwart neural adaptation, when the highest acuity is achieved, our eyes are actually not completely motionless, but we make these small miniature eye movements, which are called fixational eye movements. So Martinez-Conde's lab, they did a very elegant experiment in which they recorded eye movements in subjects, normal subjects, when they were looking at a similar stimulus. They had the subjects push the button when they perceived the stimulus to disappear and release it when it reappears. And what they found is that microsaccades or fixational saccades, they increased during intensification and decreased during fading of the visual stimulus. So to just reiterate, fixation eye movements, they play an important role. They counteract visual fading by thwarting neural adaptation for both foveal and peripheral targets during prolonged fixation. So why are we interested in this? But before I go that, I just wanted to describe the features of fixation eye movements and show you a video of an eye tracker while we were measuring the eye movements. So notice that the pink and the green, which are the right and the left eye, when looking at a dot, they are not perfectly still, and we make these small eye movements, and that's what we are going to talk about today. So here's a sample of eye position traces obtained from a normal control. X-axis is time and y-axis is horizontal and vertical eye position of the right and the left eye. And normally we make these small fixational saccades indicated by these black arrows that alternate with periods of intersaccadic drifts. And typically we make about 1 to 2 per second of fixational saccades. They are binocular and they are conjugate movements. Now, frequently fixation eye movements are quantified using a measure called bivariate contour ellipse area. What this is basically when you plot horizontal and vertical eye position on X and Y axis, you get this cloud of fixation points. And so the more stable the fixation, the points are going to be tightly packed together. And when you fit an ellipse to this area, that area is the bivariate contour ellipse area. So the smaller the BCA value, the more stable is the fixation, and there is less fixation instability. Now, moving on to fixation instability in amblyopia, which has been reported by a number of labs. So amblyopia, as we all know, it's a neurodevelopment disorder secondary to abnormal visual experience during early childhood. And what we did in our study is that we wanted to characterize what causes fixation instability in amblyopia and then examine the effects of FEM abnormalities and how they correlate with visual function deficits seen in amblyopia. And finally, examine the link between FEM abnormalities and treatment outcomes. So we recorded horizontal and vertical eye positions from 115 amblyopic subjects when both eyes are viewing, when the fellow eye is viewing, and when the amblyopic eye is viewing. We use a remote video eye tracker, which has a very high sampling rate and spatial resolution, and the setup time is less than 2 minutes, making it ideal for recordings in children. And here's the distribution of the subjects. We had 1/3 controls, 1/3 were anisometropics, 1/3 were mixed with very few pure strabismics. And then when looking at severity, we had mild and moderate, and then some severe amblyopes. We divided amblyopic patients into 3 groups. The first group was amblyopic patients who did not have any nystagmus. So here again is a video recording, eye movement recording from a severe amblyopia patient. The green is the fellow eye and the magenta is the amblyopic eye. And notice when both eyes are viewing, you see this drift in the amblyopic eye. So when we look at the eye position traces obtained on the binocular fellow and amblyopic eye, the red trace here is the horizontal eye position of the amblyopic eye. Notice that there is that increase in the drift here. The drift is again evident during fellow eye viewing, and then when the amblyopic eye is viewing, in addition to the drift, there is an increase in the amplitude of the fixational saccades. So collectively, the increased amplitude of fixational saccades and the increase in the drift, they cause the fixation instability, as is evident in all 3 viewing conditions, including during binocular viewing, where the amblyopic eye is much unstable compared to the fellow eye. Now we know that patients who have experienced disruption of binocularity in early infancy, they develop fusion maldevelopment nystagmus or latent nystagmus. So here's an example of a patient who had manifest latent nystagmus, because these recordings are obtained when both eyes are viewing and the nystagmus is evident. And when you look at the eye position traces, again, during binocular viewing, you see the nystagmus, there's a quick phase followed by a slow phase. This is when fellow eye is viewing, and this is when amblyopic eye is viewing. And the key feature here is that the direction of the nystagmus reverses from fellow versus the amblyopic eye. So when it's always beating temporally. The quick phases are always temporal, and this is like the telltale or signature hallmark that can be delineated very easily on eye movement recordings. And then, of course, in this patient, since they have nystagmus, there's an increase in the instability, which is particularly high during amblyopic eye viewing condition. Now, we found that there are patients with amblyopia who have nystagmus, but they don't fit the criteria of FMN. And these patients are different than those from congenital motor nystagmus, because they do not have the increasing velocity waveform that you see with congenital motor nystagmus. So here's an example of one such patient who had nystagmus, but did not meet the criteria of FMN. And this is what the eye movement traces show. So the nystagmus is most pronounced during amblyopia eye viewing. Notice that during fellow eye, there are some nystagmus beats, but you do not see the reversal in the direction of the quick phases like you see in FMN. And again, these patients have increased instability, which is particularly worse during amblyopic eye viewing. So when we look at the FEM waveforms across different types of amblyopia, what we see is that anisometropic amblyopes, they generally don't have nystagmus, or if they do have nystagmus, it's usually nystagmus without FMN. On the other hand, patients with strabismic amblyopia, they tend to have nystagmus compared to the anisometropic amblyopes. And then patients with mixed amblyopia, they were 1/3, 1/3, 1/3, where 1/3 did not have nystagmus, 1/3 had nystagmus without FMN, and then 1/3 had FMN. So the next thing I want to talk about is, why is it important to characterize this fixation stability? So recent research has suggested that amblyopia is not a simple monocular problem, but it affects both binocular and monocular functions of fellow and amblyopic eye. And our work has shown that the timing of amblyopia plays a role in the extent of visual function deficits seen in amblyopia. So with presence of FMN, there's greater impairment in binocular and some monocular visual function deficits of the fellow eye. So here I'm going to talk about contrast sensitivity measurements. We did contrast sensitivity measurements at low spatial frequency and at high spatial frequency. In low spatial frequencies, the bars are wider. In high spatial frequency, they're closer together, so it's a relatively hard task. And I'm going to show the data that we collected from the fellow eye, or the good eye, so to speak. And we divided the amblyopes into no nystagmus, nystagmus without FMN, and FMN. The black traces are at the low contrast, and the white traces here, bars, are the high contrast sensitivity. So in controls, the low spatial frequency contrast, the thresholds were better compared to the high spatial frequency, as you'd expect, because it's a more difficult task. Now, interestingly, the fellow eye of patients both with and without nystagmus, all three groups, they had the thresholds for the high spatial frequency, which were much worse compared to controls. In addition, patients with FMN, besides the low spatial frequency was also affected. So this shows that the fellow eye of amblyopic patients, both with and without nystagmus, have abnormal contrast sensitivity. Patients with FMN have more deficits compared to the other two groups. Next, I'm going to switch gears and talk about FEM abnormalities and its link to patching treatment. So patching is the gold standard. And we know that despite good compliance, about 40% of patients, they have residual or recurrent amblyopia. Studies have shown that if there are certain predictors that can predict patching treatment response, including if you were diagnosed at a later age or you have more severe amblyopia, you're more likely to have residual or recurrence of amblyopia. But besides that, what we wondered is that can FEM abnormalities be linked to treatment outcomes for patching treatment? So we know we'd seen previously that during amblyopic eye viewing, the FMN can get worse. So here's a plot showing the amplitude and velocity. The red traces are when during monocular viewing, and the black traces are in binocular viewing. And notice that the amplitude and the velocity, they're shifted to the right, so they have greater amplitudes and velocities in monocular viewing. And so our question was, does the presence of FMN determine treatment response? In other words, patients who don't have nystagmus, do they respond better, do have greater and quicker response to part-time patching than those without FMN? So to answer this, we recruited 53 amblyopic patients. We measured their fixation eye movements, and 21 had no nystagmus, 21 had nystagmus without FMN, and 11 had FMN. The age at treatment, they were all about 6 years of age. The severity, 3 had mild, 35 had moderate, and 15 had severe amblyopia. And then we had 19 anisotropes, mixed were 28, and strabismic were 6. And we looked at 3 outcome measures. These were assessed after visual acuity had stabilized with no further improvement or deterioration at 2 consecutive visits, at least 6 weeks apart. And we looked for the amount of visual acuity improvement, stereopsis at the end of treatment, and the total duration of treatment. So first, I'll describe these outcomes as a function of type of amblyopia, clinical type of amblyopia. So here's the visual acuity improvement and patching duration. The patching duration was pretty similar, maybe slightly higher for the strabismic, and perhaps there was some suggestion that mixed amblyopes tend to do a little worse compared to the other 2 groups, but none of this reached statistical significance. Now, when we looked at these outcomes as a function of fixation eye movements, it was pretty clear that patients with FMN, they required longer durations of treatment. Also, the extent of visual acuity improvement was less in patients with FMN compared to those without nystagmus, but it did not reach statistical significance. So the other thing that we looked at is the final stereopsis at the end of treatment. So for the type of amblyopia, anisotropes tend to have better recovery of stereopsis compared to the other 2 groups, as well as patients who have FMN, they really did not have much improvement in stereopsis. So we have converted these values in log arc seconds, and if they didn't get the fly on the titmus, we assigned them a value of 3.2 log, and you can see basically most of the patients with FMN, they did not have any improvement in stereopsis despite showing improvements in visual acuity. Next, I want to switch gears and talk about how FEM abnormalities can be useful to understand dichoptic treatment response. So there's data suggesting that dichoptic treatments are non-inferior to patching treatment. However, randomized controlled trial have shown a mixed result. PDIC did a big study, and there are some other studies out there where they have found that there are patients who, after dichoptic treatment, don't have improvement, as good of an improvement in visual acuity. And so we wondered whether eye movements can help us understand the treatment response. And so what we did is we again measured fixation eye movements, but this time, rather than just looking at a dot, this was a dichoptic stimulus. So each eye was presented a different contrast, if you will. The fellow eye, the contrast was varied at 100%, 50%, 25, and 10%. And the amblyopic eye, the contrast was kept constant at 100%. And we measured their eye movements using the eye tracker. What we find is that patients, this is an example from an anisometropic patient with amblyopia, and the blue traces the fellow eye and the red traces the amblyopic eye. Notice that even at 100% contrast, the amblyopic eye is pretty unstable. But then as you lower the contrast of the fellow eye, the instability tends to increase, even in the fellow eye. So perhaps the increase in instability would make it hard for that eye to attend to the images that are being presented and perhaps contribute to less treatment response. We also saw that patients who had strabismus, here again, we plot the strabismus angle, and here's a histogram. The cooler colors are at the higher contrast to the fellow eye, and the darker, and the yellow and the red is when the low contrast is shown to the fellow eye. The strabismus angle gets worse. So again, if a patient is looking and doing the treatment, if the eye is more deviated, the amblyopic eye, then it's less likely that there would be treatment response. So with that, I would like to conclude that amblyopic patients, both with and without nystagmus, have increased fixation instability. FEM abnormalities correlate with binocular and monocular visual function deficits. Patients who have FMN require longer durations of part-time treatment, patching treatment. Despite modest improvement in acuity, stereo recovery is poor in amblyopic patients who with FMN that are treated with part-time patching, and perhaps fixation instability and strabismus angle changes in the dichoptic environment, particularly low fellow eye contrast, could be responsible for having mixed results with dichoptic treatment. I'd like to thank the funding agencies and the lab members that help us put this work together, and I'll take any questions. Okay.
Ma'am, probably we'll start taking the question at the end of the session.
Okay.
Yeah, it was a delight hearing you, ma'am. And we can proceed further with Dr. Joseph. And over to you, sir.
Unmute and start the video. Welcome everyone, and thank you very much for this opportunity to join you. I need to select my appropriate screen. And I hope I am sharing at this point in time. Oh, I'm sorry, it says that the other participant is still sharing. Is it possible that?
Visible, sir. Yes, screen visible.
I can, I don't think I am sharing. You cannot start while the
I'll try another try. I'll make another attempt.
Your slide visible, sir.
Say again?
No, sir. Your slide is visible, sir. Okay, sir.
Am I presenting at this point?
Okay.
Yes, we can see your slide. Thank you.
And do you have video of my face?
Yes, sir. Yes, sir.
Okay, thank you. Well, again, I'd like to thank everyone for the opportunity to join with you today. And my topic for today is telemedicine, distance and near visual acuity tests for adults and children. And the purpose of this talk is to recognize the impact that COVID has had on all of our practices and the necessity for us to have adopted new manners of testing vision, and to recognize the fact that the most fundamental ocular sign, the most fundamental sign of ocular health or vital sign is visual acuity. So with that, let's see what kind of tools are available for us to measure visual acuity by telemedicine. First, I did a search in the Apple Store and found that there were 10 apps that were listed under the search for visual acuity test. And honestly, I didn't recognize any of them. And this was confirmed to the next step when I went to the Google Play Store and found 249 results under the search term visual acuity test. Most of these apps had some attempt to measure acuity, and most of them appeared to present with a simple scanned JPEG of a Rosenbaum near card, although there were some serious efforts to be found. One of the less serious efforts that I thought was just fun to read about was a test called How to Improve Eyesight. The company that presents it is called The Almighty Dollar, and it presented the kinds of information that you would find under Quora's response to how do I get better vision. Suggestions such as warm your eyes by palming, rolling your eyes, focus on a pen doing pencil push-ups and equivalent, massaging your temples, and my favorite, take a mini nap, were listed under exercises to improve vision under the search term visual acuity testing. So our department needed a visual acuity test, and I didn't think we were going to get anywhere with this one. And I came to the conclusion very quickly that if you go to the App Store, you may find something if you're technically savvy and if you wish to direct your own healthcare, but it does not necessarily represent a solution for physician-directed care. I concluded that apps in general are iffy, but specifically there are several that are listed that are appropriate for screening if an individual wishes under their own direction to monitor for change in vision or for simply exploring information about vision. But they're not appropriate for individuals with lower technical competency, individuals who have lower access to quality hardware, and most importantly, for use by us as clinical decision makers, unless they have been previously validated. I talk about two resources that I did find online that have been published since the start of the COVID epidemic, and which I think represent real efforts in order to improve online measurement using resources that can be downloaded or obtained by patients. The first I'd like to mention is the Go Check Kids digital visual acuity test app. Most of us know Go Check Kids for the photo screener that they have developed based on the iPhone, but this is a visual acuity test that is reminiscent of the ATS HOTV protocol. It's an iPhone app, and what is happening with this is that within the app, a line of randomized order H, O, T, and V is presented on the top of the app display, and then underneath it is a scaling smaller progressively one of four letters. So the task of the child is to look at the lower, in this instance, T, and find where it matches on the top line. And the way the match is identified is through the child indicating by pointing whether the T that they're looking to match with is to the left or to the right. So they would point to the left or to the right, and then the operator would do something along the lines of a tip. You can see that the letter H, that the letters that they're being tested are getting progressively smaller. And so it's harder for the child to see where to match. That's a very clever application. Again, it's not the HOTV protocol, it's an ATS-like protocol. And it's a protocol that is intended for use specifically with the iPhone, and it has pretty good results. Dr. Silverstein did an evaluation of this with 53 children, and while there were significant differences at the statistical level, the differences may be statistically significant, but less clinically significant. I draw your attention to this line down here that says the percentage of eyes with visual acuity measured by Go Check Kid within one line of the HOTV ATS and chart acuities were 65% and 86% respectively. That's a pretty good, that's about as good as most visual acuity tests agree with each other within a line. Within 7 letters is the standard of statistics. So the conclusion that was produced by this test was that this Go Check Kids Act, if used properly at a distance of 5 feet, provided modest correlation of visual acuity compared to the chart and fair correlation with the HOTV study within one line. That's pretty good. And that was in American Journal of Ophthalmology in this year. Another test that has become available online that you might have read about in journal JAMA was the Moorefield's eye test, which uses a rather different approach to visual acuity testing. This is intended for a close cooperation with a tester at the other end who, someone goes online, they go to this website, homeacuitytest.org, and they request a printed eye chart, and one of 58 quadrillion unique charts will be printed for them. That's a tremendous number. It's not an ETDRS chart. The chart is a half octave, meaning every other line doubles in size. And instead of 5 letters per line, there's only 4 letters per line. But what will happen is that at a distance of 5 feet, a score sheet will be filled out by a helper, and then Moorefields will be talked with on the telephone for the right eye and the left eye score, and they interpolate these 18 symbols to an HOTV or an ETDRS acuity. And again, it was evaluated, and the evaluation, again, coincidentally, was of 50 patient subjects of controls and 100 ophthalmology patients. And the take home here is that there was good agreement in visual acuity for the ophthalmology patients, that a one-line difference occurred on average, and that the logmar, one line on a logmar chart is 0.1. The range was pretty typical of several lines, but with an average of 1 line difference. So 2 options that are available, one an app, one a printable, somewhat unusual and requiring operator intervention in real time printed test. I'd like to describe work that we have developed here at the University of Arizona to try and address this problem as well. And it's available through the Journal of APOS. It was published in August of 2020. And it's telemedicine distance and near visual acuity tests for adults and children. I'd like to acknowledge my co-authors, Kevin Jang, Divya Ramesh, Dr. Marshall, Selene Yeskis, and Dr. Harvey. So what we were looking for was early in the pandemic to develop a home-based acuity measurement that was available to all of our patients, not just the most technologically savvy. And we proposed to distribute eye charts and instructions, as well as an Amsler grid and near cards, as either PDF files for printing or JPEGs for electronic presentation, with the idea that a patient would be scheduled for an appointment and we would email these documents to them. We recognize that most homes don't have 10-foot lanes and that the rooms need to be shorter, so we developed it for a test distance of 1.5 or 3 meters and implemented the ETDRS R chart, the refraction chart, for adults, and a similarly designed HOTV chart in ETDRS format with a matching card for children, and designed it for an optimal test distance of 1.5 meters, which corresponds to English 2200 to 2016 or metric 640 to 64.75. Now, calibration is always an issue for these. And so at the bottom of the chart in the corner is a 25 millimeter diameter image of our US quarter, or incidentally, the same diameter as your 2 rupee coin, 25 millimeters. So the idea is that if the chart is printed out properly or displayed properly, this image of the coin will match the real size of the coin. So you have to find a coin and check the size of the chart to make sure it's properly scaled. Now, if you've got an email, perhaps you got it at an internet cafe, then you would use the printer of the internet cafe and print out the charts along with the instructions. A matching card is shown here, along with the HOTV Logmar format. And then you would take it and lay it down after it was on the printer and confirm that the calibration is correct. On the other hand, if you have a tablet computer, a laptop computer, or a computer with a display at home, and you can get 5 feet away from that device, then it's easier to email a JPEG image of the HOTV chart itself. It seemed to us that at this point, everybody knows how to look at a picture on their iPhone or their mobile device. So we just mail them what we describe as a picture and ask them to find a friend to help them have their Acuity test performed. And here's an example of opening an email, seeing the picture, and then recognizing the fact that the image is of incorrect size. So pinching to zoom until it's of the right size, and then removing the coin and scrolling the display back and forth at a distance of 5 feet, pointing out the letters one at a time and measuring which last line is the one that the patient recognized 3 out of 5 symbols correctly. So this is a format that's familiar both to us as clinicians and a format that is operable by most patients, we found. Does it work? Well, it was validated by a team from Vanderbilt University. We were very happy to find that they took advantage of this test and performed a very detailed analysis. What they did was contacted 200 patients in advance before coming into the clinic and had them test their vision at home and bring their results with them, and then have the test repeated in person. And the results there, the mean visual acuity score was 4.1 letters different between our chart, the ETDRS chart, well within the 7-letter equivalence margin. And the conclusion of this group was that the ETDRS visual acuity test self-administered following this standardized protocol was equivalent to a standardized technician-administered visual acuity test performed by the clinic. And this is a Bland-Altman plot showing the pattern of the deviation. This is difference versus mean plot. The closer those circles are to the black line, the closer there was to agreement. And the larger the diameter of circle, the more samples there were in that. Patients' acceptance of this format test was very high. 98% of the patients agreed or strongly agreed that the Acuity test was easy to set up and perform, and 94% said that they would be willing to perform the test at home. They also felt that the barriers to preventing them were low, and less than 5% of patients felt that the technological barriers were insurmountable for them. So in conclusion, I come to the conclusion that it is possible to measure visual acuity, the most basic ocular vital sign, from home for telemedicine care using validated methods. These methods include apps, electronic displays, and printed charts. Some methods are simpler than others. Some are approachable by download by the patient for their own administration. Others are sent to them by our direction under email. And I just would like to encourage everyone to think about this as, when it comes to technology, we have a tendency to think of applying technology from the hands that we have ourselves, from our own skill set. It's important to show some empathy and think about where the other person is coming from and try and meet them where they are, not where we are. Because you have to remember that not every cell phone comes with a granddaughter that shows you how to use it. With that, I'd like to say thank you and wish you all well with your surge of COVID and your recovery. It was horrendous here in Arizona. We wish you the best, and our prayers are with you.
Thank you so much. All the delegates, all the attendees can use the Q&A tab, which is mentioned below on the screen, for all the questions, and we can take them at the last of the session. Following by the next, we have Professor Donnie. Proceeding to you, sir. Professor Donnie?
Can you see me okay?
Yes, sir. Good morning.
Okay. Thank you. Thank you. Gosh, excellent presentation. So first of all, I thank you very much for this opportunity to attend the 79th annual conference for the All India Ophthalmologic Society. I do know that this is a very, very prestigious and well-attended meeting. And it's one of the most recognized meetings in the world, actually. And we're all very sad on behalf of the American Academy of Pediatric Ophthalmology and Society that we cannot be there in person. But hopefully in 2022, we could be there in person and share great camaraderies. My topic is on abusive head trauma. It's not specifically abusive head trauma, it's about ocular traumas, but I want to thank my co-investigators first. We have a case here, a 7-month-old child that came in, had a fever, vomiting overnight, and started having some seizures, and CPR was initiated and then was brought to the emergency room. And patient had a retinal findings like this. And then a day later, unfortunately, the baby expired, passed away. Of course, in situations like this, we go through extensive differential diagnosis before we come up with the diagnosis of possible shaken baby syndrome or abusive head trauma. So I just did a little bit of history. The first case of abusive head trauma was actually reported in 1868. And since then, there were some few anecdotal reports, and it actually went through many different names over the years. Starting with battered infants, now we're using abusive head trauma, but soon I think that may actually change. How big is this problem? It is the single most common cause of traumatic death in children under the age of 1. And the impact of COVID-19 is still not known, but some speculate that there's probably a significant underreporting. So this is a big concern. And unfortunately, the 80% of the survivors also have a permanent sequelae in forms of motor, intellectual, visual deficits. So it is a big problem, even for the babies that survive. Today, the shaken baby syndrome is actually still one of the most common cause of death. Even today, it's one of the most common cause of death in children under the age of 2. Why is that? Well, possible causes include a lack of awareness and doubt. If you don't have to look very far, just going to your computer or your phone and type in abusive head trauma. There's many articles out there by reputable, so-called reputable journals, the Anchorman, and actually there's even a movie that's made of that doubts the existence of abusive head trauma. And also our researchers actually have published numerous papers on how it is impossible to generate enough force to cause retinal hemorrhage with shaking in humans. And because of this, this actually was a big concern of mine. And even today, there's a cultural barriers and lack of reports on shaken baby syndrome. As a matter of fact, many parts of the world, we don't really have abusive head trauma reports in peer-reviewed journals in many countries. We actually understand what goes on in the brain, with the brain shifting back and forth with the coup and counter coup, but we really don't have a clear understanding what actually happens in the retina why 90% of the patients with this condition develop retinal hemorrhage. And it's not just a simple retinal hemorrhage, but this retinal hemorrhage actually occurs throughout the entire retina in the pre and intra and subretinal areas. And as we all know, there aren't too many conditions that can actually cause that. And on top of that, this actually, the retinal hemorrhage is not localized to the posterior pole, but its entire periphery. And why is that? Possible theories include increase in intracranial pressures, but the second, the more likely that the theory is that there's a significant vitreoretinal traction. What does that mean? Well, here's an eyeball with the gel that's inside. As this gel is sliding back and forth, it can actually cause traction and resulting in shearing force. But and OCTs on some of these cases actually have nicely shown a focal vitreoretinal traction with the PVD associated with the preretinal hemorrhages, along with the retinal schisis, as you can see. But it is not a simple translational force. It's not a simple shearing force. Here's an hourglass with the oil on top, water on the bottom. As you can see, when you're shaking this hourglass tangential to the interface, the interface is not going to be disrupted. But as I've told you, the intraretinal hemorrhage is actually the entire retina. It's not just in the posterior pole. It's not just localized to one quadrant, but it's entire retina. And that's probably because of this torsional component. What does that mean? Just with a simple, gentle torsion, you can actually disrupt the interface very easily. So it is not just a translational, but that torsional component plays a very important role. So the big question is, I get asked by the lawyers, how much is that force? Is that like a car? Is that a force that's consistent with the car accident? Is that consistent with just you wearing being in a car seat with a belt, like just with a simple vibration? Is that enough? What is that force? So my objective was to determine that force, and I wanted to find. My goal of my research was that I wanted to determine various forces that the vitreoretinal traction that's produced during forcible shaking. So how much force is being created by a shaking, a child? And second, I wanted to determine how much force is required to separate the vitreous from the retina. So is shaking by simply, how hard do you have to shake a child to cause the vitreoretinal separation that is resulting in the tearing of the blood vessels, resulting in retinal hemorrhage? And also, why does it cause those unique patterns of retinal hemorrhage? And so that's what I wanted to find out. So first, we created a very sophisticated computer simulation model using a finite element. And then also we used various animal models similar to human to determine that vitreoretinal adhesions. So first here, as you can see, we created a computer's finite element that would incorporate all the properties and characteristics of various tissues in the eye. And then we also added a vitreoretinal attachment point along the retinal vessels, posterior pole, and also in the periphery, similar to human. And then we looked at over 300,000 different small points within the retina at any given point. And then we divided the retina into thirds, the preretinal, intraretinal, subretinal. And then we wanted to shake this eyeball similar to a baby doll model that was actually created by Yamazaki years ago. And he actually, what they did was that they put a accelerometer in the eye and also in the perpetrator's hand, and they shook this baby. And what they found was that it was this pattern. This is the position, exact position of the eye. So it's a figure of 8 in this fashion. So we shook this a finite element identical to this Yamazaki eye model, and we created this heat map. And then warmer the color, greater the force. And what we found was that the average stress along the vessel was about 7 kilopascal. And wherever there was a bifurcation, because there's a additional adhesion of the vitreous to the vessels, that force increased to 9 to 10 kilopascal. And then also we looked at the forces in various retinal layers, and we found that it was actually pretty similar in all 3 layers, and it was not statistically significant. So we compared this to a soccer ball injury. And so here's a force, here's a collision of the soccer ball. And then as you can see, this force is transmitted in a translational fashion, and there's really no torsional component. And what we found was that after that initial contact, that force declines dramatically. And also the subretinal and pre-retinal, the layers of the retina had statistically different amount of force that's experienced in comparison to the abusive head trauma. And we went to the animal model, and we actually looked at the sheep. And there's a lot of reasons why we looked at the sheeps. It actually had been well studied in the past. So we created a small opening in the sclera, and then took out the RP layers and left the retina intact. And then this retina was glued to a plastic that we call PTFE, and was glued with various materials. And we actually had ended up using polyurethane for various reasons. And then we placed it in a load cell, and we gradually separated the plastic that's glued to the retina, and we gradually separated it, as you can see here. And we registered the force that's required to separate that vitreous from the retina, as you can see right there. So for this particular model, as you can see, that force was about 2.5 kilopascal. Here's the retina, and here's after the retina is taken out. And we confirmed it histologically. So the result was that the average stress was 2.72 kilopascal, and that number increased at different angles. So what we found, and we repeated it at different angles, and then we also repeated it with different animals. We used monkeys, and as you can see the force, and we found that the force was actually even less for young monkeys of 1.2 to 1.3 kilopascal. So what we found is that using our computer and animal models, we supported the hypothesis that shaking an eye at a frequency as low as 2.2 kilohertz can produce a stress level that exceeds the minimal threshold for producing vitreoretinal separation in young sheep and monkey eyes due to mechanical failure. And as you saw, that force actually increased over time. And that similar type of mechanical failure can easily occur in human eyes if the stress level exceeds the vitreoretinal adhesions. And also, wherever there was a bifurcation, it actually experienced a greater stress. So in peripheral retina, of course, there's a greater number of bifurcating vessels. This explains why there's a diffuse nature, the diffuse nature of the retinal hemorrhages and shaken baby syndromes. And also, the pre-intra and subretinal layers experienced a similar stress level this actually explains why there's a significant retinal hemorrhages in all 3 layers. So in conclusion, our finite element can be used to recreate a trauma based on the history that's provided and calculate the force and the pressure applied to the retinal structures and correlate that with the clinical picture to see if they actually match. And if they do not match, and of course, we would need to pursue further and looking at the medical and social history investigations and the circumstances surrounding the traumatic event. Thank you very much for your time, and I'll be happy to answer any questions after our symposium. Thank you.
Thank you so much, sir. Proceeding further, I invite Dr. Aparna. Over to you, ma'am.
Thank you. Thank you very much for this opportunity to present a topic of great interest to me. I am a pediatric ophthalmologist and an ocular oncologist at Phoenix Children's, and hopefully I'll provide some clinical pulse on ocular oncology for the pediatric ophthalmologist. I don't have any financial interest associated with the talk. So we'll just go with rapid pictures and clinical pearls. This, as you can see, this is a child with some pigment in the sclera. This is actually nevus of aorta. It is usually associated with pigment in the eyelid. It's associated with pigment in the conjunctiva. The ipsilateral iris is usually more pigmented than the other eye, and there can be some pigment increase in the fundus of the same eye. Incidence of melanoma is 1 in 400, and oftentimes it can be a multifocal melanoma. But more commonly, you can see glaucoma. So hence, it's advisable that you do gonioscopy in these kids at least once a year. And if you do see evidence of glaucoma, it's usually treated very similar to pigmentary glaucoma. It can sometimes also be associated with pigmentation of the ipsilateral palate and the meninges on the same side. So that's why I always advise that, all nevus of aorta kids, I do look into their mouth to see if I see a pigment in their palate and see if there's any change in that palatal pigment. Routine MRIs is usually not advised, but I will usually, if a child has some neurological symptoms, then you can get an MRI, because very, very rarely you can have a melanoma that arises in the meninges, and again on the ipsilateral side. Going to our next condition, this is something we all see very commonly in our pediatric practice. It's a limbal dermoid. In this kid, it is associated with a golden heart syndrome, which is associated with preauricular appendages, oral fistulas, microtia, maxillary or mandibular hypoplasia, vertebral anomalies, and in the eye, you can have an eyelid coloboma and Duane syndrome. I usually do not try to excise them unless it's causing significant vision problems, either by obscuration or by causing significant astigmatism. Because sometimes the surgical scar produces more astigmatism than what the original lesion was causing. So I try to observe as much as I can. Coming on to pigmented conjunctival lesions, this is a child that presented with a pigmented lesion. Now, whenever you see pigmented lesions in the conjunctiva, there are 4 main things that we think about. One is complexion-associated melanosis, previously called as racial melanosis. Second is primary acquired melanosis. Third is conjunctival nevus, and then conjunctival melanoma. Fortunately, in kids, almost majority of conjunctival nevi are benign, and even when they're excised pathologically, they show benign features. So it's very rare for conjunctival pigmented tumors to be malignant, but still it's good to keep an eye on them. The first picture that you see on the top here is complexion-associated melanosis. It's usually associated with a darker skin complexion. It's usually a bilateral condition where you see diffuse scattered pigments all over the limbal conjunctiva. The picture on the side is primary acquired melanosis. Again, this need not necessarily be perilimbal. It's a scattered pigment, and it's kind of just blotchy pigment that can be in just one quadrant, or it can be a little more diffuse. But if you look at the contralateral eye, you would usually not see the pigment that you see in complexion-associated melanosis. The picture that was seen in the earlier slide, this one is a characteristic conjunctival nevus. And if you see carefully, you can actually see cysts in the lesion, which are very easily seen in the slit lamp. So once you see that, you know that you're likely dealing with an nevi. And of course, this picture here is a picture of a melanoma. Now, as a general dictum, whenever you see pigmented lesion in the fornix, tarsus, or the cornea, it's likely pre-malignant or malignant, and it should be excised. Coming on to this picture, you see a little bit of an anisocoria. The right pupil is larger than the left pupil. And then when you look at the child in light and dark, the anisocoria is accentuated by dim light. So this is a Horner syndrome. Whenever you have a child with Horner syndrome, you have to do a cross-sectional imaging of the brain, neck, and thorax. And it's also a good idea to get urinary catecholamines to rule out neuroblastoma. The other thing you can do in your clinic is do an Apraclonidine test, where what you do is you baseline measure the pupils. you add apraclonidine to both eyes and remeasure the pupils in the same lighting after 30 to 45 minutes. And you'll see a reversal of the anisocoria, and you'll also often see a reversal of ptosis if it was there in the beginning. And this happens because the adrenergic receptor supersensitivity in Horner syndrome. This is a very useful test because as a test, you see a lot of physiological anisocoria in the clinic, because 20% of kids are supposed to have physiological anisocoria. So it's good to do this apraclonidine test sometimes when you're not sure if it's a physiological anisocoria or is it Horner syndrome. Coming on to tumors. This is a tumor that you see in the ciliary body region. And as you might have already guessed, this is a medulloepithelioma. It originates from the non-pigmented epithelium of the ciliary body. It usually occurs in the first decade of life. So it's usually more common between 5 to 10 years of age. So it's not the retinoblastoma age group, it's slightly older kids. Metastasis is very rare with medulloepithelioma, but often you see local invasiveness. Most medulloepitheliomas occur in the ciliary body, but rarely you can also see it arising from the optic nerve. Traditionally, medulloepitheliomas are considered to be chemo-resistant and radiation resistant. So you can attempt a local resection, but oftentimes enucleation is required for these patients. The one thing that is important to remember is that medulloepithelioma can be associated with the Dicer-1 syndrome, which is characterized by the ovarian Sertoli Leydig cell tumors, pleuropulmonary blastoma, and hamartomas polyps in the small intestine. But also there can be multiple other tumors that can be there in the Dicer-1 syndrome. So whenever you have diagnosed a kid with medulloepithelioma, it's good to do a complete review of systems to make sure they don't have any other involvement. So this is a child that presented with multiple lesions in both eyes with hemorrhages, and this child was actually in a blast crisis of leukemia. So ocular manifestations of leukemia are seen in 30% of children with leukemia. So it's way more than we think it's present. The leukemic manifestations can be either direct or they can be indirect. Direct manifestations include orbital infiltration, optic nerve infiltration, choroidal infiltration, and retinal changes that are called as the rot spots. The indirect manifestations are hemorrhage, branch retinal vein occlusion, and graft-versus-host disease if the child has been treated with a bone marrow transplantation. This is a child that was a 15-year-old kid that had previously been treated for leukemia and presented with an optic nerve appearance like this, which rapidly progressed. It was treated for a while at an outside facility as an optic neuritis, maybe papilledema, but then even the MRI was not clear-cut. It showed some enhancement. The child was already no light perception, and the lumbar puncture and the bone marrow was all negative, so there was no evidence of leukemic relapse. But with this presentation, it's a very high suspicion. So we actually had to do an optic nerve biopsy, transconjunctival optic nerve biopsy, and it showed the leukemic cells, and the child was successfully treated with radiation. So I kind of want to emphasize that whenever kids have had history of leukemia and they have some atypical presentations, it could be uveitis, it could be optic neuritis, anything, just have a suspicion that it could be a leukemic manifestation. Coming on to this child that presented with a amelanotic elevated lesion in the fundus, and after fine needle aspiration biopsy, it was suggestive of a Burkitt lymphoma. This is post-plaque brachytherapy. The child was treated successfully. And this child had a previous history of lymphoma. So this was a second lymphoma for this child, which could be either from immunosuppression or for chemotherapy. So whenever you're in doubt, you don't know what lesion it is, fine needle aspiration biopsy, though it can give you only a few cells, with a expert cytopathologist, you can oftentimes make a diagnosis. This is a child presented with bilateral presentation with multiple pigmented lesions in the fundus. And this is very characteristic for Gardner syndrome, which is an autosomal dominant condition in which you have adenomatous polyposis of the large and small intestine, hematomas of the skeleton, and various soft tissue tumors. The risk for intestinal malignancy in adults with Gardner's is close to 100%. So they often need a prophylactic colectomy. The classical eye features is the bear tract that we just saw. The eye features are 78% sensitive and 95% specific. If you do a gene test for Gardner's syndrome, even that is not as specific as the eye feature. So because it's an autosomal dominant condition, it's good to check the entire family for ophthalmic features. Probably this is the only condition where I would look at somebody's fundus and say you need a prophylactic colectomy. But what I want to emphasize is it's a very specific finding for Gardner syndrome. Coming on to this lesion, it's characteristically called as the Mulberry Lesion. This is astrocytoma associated with tuberous sclerosis. There are three kinds of astrocytomas that you can, there are three kinds of features that you can see with tuberous sclerosis. One is the elevated one that you see here. And then on the picture on the left, you see a flat astrocytoma. And on this side, you see what's called as a chorioretinal scar. It's kind of like a lacunae. Now, these chorioretinal lacunae have the same diagnostic feature as the astrocytoma. So if you look at the diagnostic criteria for tuberous sclerosis, a flat astrocytoma and a chorioretinal scar like this has a similar point for a diagnosis of tuberous sclerosis. Coming on to these spots in the iris, which are suggestive of lesion nodules and neurofibromatosis. Of course, you're really worried about the optic nerve gliomas, which are seen in 1 to 5%. Radiologically, it is seen in 15% of kids. You can also have plexiform neurofibroma, and you can have a congenital iris ectropion. And oftentimes on the ipsilateral side, you will see glaucoma. Regarding the treatment of optic nerve glioma, of course, there is traditional chemotherapy. You can treat it with radiation. You can also do surgical resection when the eye is a no light perception eye. But a lot has changed with neurofibromatosis treatment with the advent of MEK1 inhibitors. So they have really opened up a new door for treatment of optic nerve gliomas and NF1. This is a lesion with exudation and subretinal fluid, and this is characteristically seen with von Hippel-Lindau disease, which is again an autosomal dominant condition. The retinal lesions usually develop between 10 to 35 years. They're usually multiple lesions, and some of them can be very, very small. So I usually routinely advise fluorescein angiogram because some of these lesions are not seen clinically, but will be picked up on the angiogram. They're quite responsive to treatment with either laser or cryo. If it's a posterior lesion like the one picture that we showed, then you can do a photodynamic therapy. The screening should usually start at the age of 5 for all kids with von Hippel-Lindau syndrome. This is another picture where you see tortuous retinal vessels, and this is suggestive of Wyburn-Mason syndrome. Fortunately, there is no exudation, no leakage. The one important thing to remember is it's usually associated with ipsilateral vascular malformation of the brain orbit and the mandible. So you have to let the patient know that if they're having a dental extraction, that angioma can bleed and can really have a torrential bleed. This is a child that kind of presented with inflammation of the eyelid and was initially treated as an orbital cellulitis, but was actually a rhabdomyosarcoma. And actually 15% of rhabdomyosarcomas actually present as cellulitis. The other common presentation is that they have a trauma and then they have this mass appearing. So you think it's trauma related, but it's actually a rhabdomyosarcoma. It's the most common malignant orbital tumor in childhood. The most common age is 5 to 7 years. Usually do a biopsy followed by chemo and radiation. This is a child that presented with significant redness and sloughing of the conjunctiva. And this is graft versus host disease, which I think is quite underdiagnosed in children. It's seen in 60% of patients with systemic graft versus host disease. And we have a flowchart for the management of graft versus host disease. Of course, we work with the oncologist for the systemic treatment of GVHD. But the local treatment broadly, we try to decrease the inflammation with either topical steroids, or you can try anakinra, which I don't do often. You try to increase the tear production by increasing the supply with artificial tears or restasers. You can try Xiidra, but oftentimes even on top of the dry eye, sorry, I thought we had some noise disturbance.
Ma'am, actually the time was up, so if you could wind it up.
Okay, sure. So, so this is the for graft versus host disease. I'll quickly go through them. So this is a hemangioma, and in Sturge-Weber, you can have a diffuse hemangioma with glaucoma. This is combined hematoma seen in NF2. This is an iris nevus melanoma, and you look at 6 risk factors: age, the hyphema, the inferior clock arc, diffuse configuration, ectropion, and feathery margins to differentiate nevus and melanoma. This is a choroidal nevus, and you use the mnemonic TFSOM-DUH to differentiate nevi from melanoma. This is a choroidal melanoma in a child. Again, very quickly, just for retinoblastoma, I'm going to just go over to the atypical presentations. This is pseudocellulitis. This is retinoblastoma that's presenting as a medulloepithelioma in a 14-year-old, like a ciliary body mass. This is mimicking endophthalmitis with an anterior chamber reaction and hypopion. And this is RB that's presenting similar to FEVR. So in a child, if you have an atypical presentation, always think of retinoblastoma. And of course, raise awareness about leukochoria and early detection of RB. Thank you very much for your attention.
Thank you so much, ma'am. It was a delight listening to you. If we have any questions, we can come up with them.
Actually, I'm going to ask the first question to Joe. Excellent presentation. I hate to tell you, I'm actually coming up with my own app. So that, it's going to be added to that 200 apps out there. And actually, it's an app that actually measures the distance from the phone to the patient's eye automatically, so that the letters get calibrated. So you don't need to worry about the size. But what I wanted to ask you, Joe, is this. You measured the most of your visual acuity at 5 feet, which is about, that's about 1.5 meters. So do you tend to overestimate the visual acuity in patients with mild myopia? Because that's a focal point of about 0.6 diopters, and also underestimate the visual acuity for patients with the hyperopia. So how do you deal with that? Do you feel 5 feet is adequate?
It appears to be. The proof is in the pudding, as they say. But yes, indeed, the reciprocal of 1.5 meters is 2/3 of a meter. So approximately 3/4 of a diopter of myopia can be masked by a short test distance. However, the literature goes back to early studies from the VIP studies that were performed in the early 2000s that demonstrated that testability was much higher in children at short test distances than longer test distances. So as far as the trade-off goes, I think the reason for acknowledging the limitations of requiring 3/4 of a diopter of accommodation in a emmetrop or masking myopia of 3/4 of a diopter are offset by two things. The fact that you can get a 2200 line on a piece of paper when it's printed out, and the shorter test distance being better able to engage the child.
Yeah. Great.
And if I may follow up with a question for you, I would like to compliment the excellent engineering work that went into the development of your model. And I just want to make sure that I understand a fundamental theorem of what's going on there. And that is, as the vitreous becomes more firm, less elastic, and more rigid, as with decreasing age, lower amounts of shear force would be required to separate the vitreous from the retina.
Right.
And so that fits. That fits with our clinical knowledge that as children age, the evidence of shaking injury decreases, and that would occur with increasing vitreous syneresis and becoming less rigid. But are you at the point yet where you can review a database of observed retinal hemorrhage photos versus reported trauma and see how the model matches a threshold for developing trauma?
Thank you. Thank you very much. I'm so glad that you asked that question. As of right now, no. So we are working on an AI model,
Of course.
artificial intelligence model that can. I'm actually applying for a grant. So I'm keeping my fingers crossed, and if once I get this grant, then I'm going to try to make that exactly what you're talking about, trying to make that correlation using a artificial intelligence model, and that's what we are working toward.
Yes. May I follow up then with a question? If it is an artificial intelligence model that is not explainable, do you think it will be useful in court?
I'm going to just tell you that I don't know the answer to that. I don't want to. I don't want to. Tell you more than what I know, because the consequence of false positive and false negatives both ways can be extremely dangerous. Yeah, it can be tremendous. But this much I do know. Based on the history, if the child comes in with the retinal hemorrhages in all 4 quadrants, and with the history of a force that was applied to the child in a translational fashion, we could say that it's probably not consistent. But in terms of us being able to make a clear statement as of today in 2021, no. We don't have enough data.
Well, I would certainly congratulate you if for no other reason demonstrating that the pattern of hand motion and head motion and associated eye motion results in translational forces. That has been missing from so many of our knowledge base and has been the basis of so many, I think, erroneous claims by pathologists and emergency medicine experts in terms of the etiology of this problem. So thank you for that contribution.
Yeah, thank you. I'm going to actually follow up with another question for Fatima. Excellent presentation, Fatima. Sorry if I'm not saying it correctly. The FNM, the manifest nystagmus, right? So how do I, like a patient with a mild cases of a manifest nystagmus, are we able to detect it? So how do you know who has FNM versus none, like no FNM? So is that something that we as clinicians can detect? Or is that
good?
Yeah.
Right. So, I mean, there are, so obviously although I look at the eye movement traces all the time, when I'm looking at kids in the clinic, frequently I don't see it. And so that's where the view of eye movements come. Having said that, when I see a patient who has 20/40 vision, whose strabismus overall is pretty well controlled and their stereopsis is pretty bad, I do suspect that they might have FMN. And so one trick, a couple ways you can maybe look for it is at the slit lamp, because it really magnifies. You have them AB duct their eye, so it might be evident. And then if it is, you have them cover the other eye and you see if the beats are now temporal and they reverse. You can also sometimes pick it when you're doing the indirect ophthalmoscopy. Again, if you have them their eye covered, you can start seeing the nystagmus. You take their hand off and it stops. So I think if you had an older child, if you had somebody where you can't explain why the depth perception has been poor, there's history that this has been ongoing since a young age, those are some clues to look for when you're examining them clinically.
Do you ever see cases where it actually, with the resolution of amblyopia, with a successful treatment, based on your report, it sounds like the the rate is low. But let's say you do have a case. Let's say you have a case of a successful amblyopic treatment. Does can this go away? Can you make it disappear?
So I've actually been doing eye movement recordings for over 8 years. So I have some children that I had followed through the years where I had done measurements on them initially, and they had good treatment response. And down the line, they continue to have the FMN, but the intensity can change. So it becomes less noticeable even on the eye movement traces, but if you look carefully you will see it. So I don't think it goes away completely, but perhaps, you know, I've seen it in a few kids who, and all of them actually ended up with having mild amblyopia where they were 20/25 to 20/30. The stereo was still poor, but their nystagmus, the FMN with time, well, you know, it was not obvious, you know, like I have 5 years apart reading on a few patients, and you can see that the intensity changes with time. And that has been reported where FMN can now, you know, if they have moderate to severe amblyopia, I've had a few of those too. And in those cases, I don't really see a change. So perhaps that might be, you know, related to treatments, you know, that's a possibility.
Mm-hmm. Okay, great. And one last question for Aparna. Again, great summary of, very, for these difficult cases. As you have talked about, up to 20% of the patients can have anisocoria. And actually, and we as pediatric ophthalmologists see these patients all the time. They come in with the, anisocoria. And as you have stated, I completely concur that apraclonidine is extremely helpful. But down to what age would you consider doing it? Because you have a child that comes in at 6 months. It's like or they bring a brand new child, newborn. So at what age would you feel comfortable? Number one, and number two, let's say you're kind of like at that threshold, and you really don't want to send them to a brain scan, and apraclonidine is a good test, and you just kind of bite the bullet and do the testing. Then how long do you observe this patient before they go home, or what are some of the things that you tell the parents before they go home, and what to look for?
So apraclonidine, traditionally, I always thought I had a cutoff of 6 months. I would do 6 months and above, I would do apraclonidine, and under that I would not do.
What percent? What percent?
0.5.
Okay, perfect, good.
Yeah.
Just for the general audience. Okay.
Yeah, 0.5. Yeah. So so there is this data from Children's Pittsburgh that they presented, where they even treated younger kids with good safety. So now I'm open to doing it for a younger child. If it's a younger child, I would observe them at least for, an hour and a half before I send them home. For an older child, I usually, after my half hour, 45 minutes, I've looked at the pupil, seen if there is a reversal or not, I'll let them know. And then I would just, mainly to look for, sluggishness, sleepiness, not normal activity. If any concerns like that, I usually say go to an ER or, urgent care. But I have not had trouble of toxicity with 0.5% apraclonidine. So far, I've, fingers crossed, I've not got called saying this kid has an adverse reaction.
Aparna,
but like you said, very useful because we see so much physiological anisocoria.
Right. We actually use plus optics, on everybody in our clinic. And of course, the plus optics take advantage of the infrared. So it picks up anisocoria, and that number 20% is, I think that number should be more like 80%. Yeah. But just to let you know, I actually did have a patient that actually had a significant side effect that actually had to send to the ER. The child, I believe, was it's 6 months old. So I think that is something that we do need to, because as you know, it does cross the blood-brain barrier. And that is something that we need to be cautious of. But I agree. I think it's a very
premature
good,
baby. I try not to use it.
Yeah.
Sorry. If it's a premature baby, I try not to use it, even if they're less than 1 year. So because I think they can have a higher side effect.
Yeah. Perfect. And then also, like again, along the same line, let me ask you: if a child comes in with a complete isolated anisocoria with no ptosis, no reverse ptosis, no heterochromia. What is your clinical suspicion? What's your suspicion for Horner syndrome in situations like that?
So if it's long-standing, and if there is no significant dark light dissociation, then I would just monitor. I would not scan them.
Mm-hmm. I agree with that completely.
I have to have some other feature other than just the nisocoria.
That's right. That's right. I actually looked at my patients over 20 years, and I personally, of course, there's some anecdotal reports of Horner syndromes with just isolated anisocoria, but over 20 years of patients that I've seen, I have not seen a patient with the Horner syndrome, which is pure isolated anisocoria with no other clinical findings. So I concur with you. Thank you. Well, I know for Fatima, I know it's getting very, very late. So,
Dr. Fatima or Dr. Aparna would add up to any comments?
I was going to say for the apraclonidine, we've also used that in congenital glaucoma while you're waiting for surgery, and in younger, babies who are younger than 6 months, and if you need it in the short run, we've used that before. So overall, I think, yeah, I'm more open to doing it in younger children than, the alpha-GAN, obviously, because of the tolerance.
Well, I think that's it. I'm going to say, well, thank you very much for inviting us. It's a truly, on behalf of all the speakers here, I think we're truly honored, and we wish you all the success. And like I said, I know how big this meeting is in India, and we're all truly honored. Thank you.
Thank you so much. It was a quite insightful panel discussion. With this, I end for the panel discussion and the session. Thank you so much, all the panelists. Thank you so much. Yeah.
Thank you. Thank you, everybody. Thank you, Aparna, Fatima, and Joe.
Bye.